Good morning, everyone. Today I am going to tackle one of the most common and most challenging presentations we see in the emergency department, abbreviated as ED, the patient with acute transient vestibular symptoms. As many as two-thirds of acutely dizzy patients who walk through our doors report intermittent symptoms only. By the time they reach us, the nystagmus we are looking for has often already disappeared. This creates a real diagnostic dilemma. We are left with recall bias, a very broad differential diagnosis, and the constant worry of missing a vertebrobasilar transient ischemic attack or early stroke. The stakes are high. There are more than 4 million emergency department visits every year in the United States for vertigo, dizziness, or imbalance, generating over $10 billion in costs, and we know that early MRI diffusion weighted can miss up to 50% of small brainstem strokes. In this talk, based on a recent comprehensive review by Tarnutzer, Lima Neto, and Diego Caschi, published in Brain Sciences, we will walk through a practical evidence based approach under following points. Number one, how structured history taking using timing and triggers, the titrate framework, immediately narrows the differential. Number two, why the single most important question is, are the symptoms still ongoing or have they already resolved? Number three, when hints plus is appropriate and critically when it is not. Number four, why standing algorithm is usually a better choice for the transiently dizzy patient. Number five, how to distinguish benign paroxysmal positional vertigo from central positional vertigo and vestibular migraine on positional testing. And finally, how to avoid the two diagnoses we cannot afford to miss, the vertebrobasilar TIA and its great mimic, the vestibular migraine. By the end of these slides, you should have a clear stepwise diagnostic algorithm you can apply the next time a patient says, Doctor, I was dizzy this morning, but I am fine now. So I start my title slide here, a guide to patients with acute transient vestibular symptoms in the emergency department. Choosing the right bedside test when hints plus applies, when standing is the better option, and to how to build a diagnostic algorithm for transiently dizzy patient. Why vestibular symptoms are hard to diagnose. As many as two-thirds of acutely dizzy patients presenting to the emergency department report intermittent symptoms only. By the time they reach the emergency department, the sign the physicians needs most, the nystagmus, has often already disappeared. So, two-thirds of acutely dizzy patients in emergency department report only intermittent symptoms. There are 4 million and above annual US visits for vertigo, dizziness, in imbalance. Up to 50% of false negative rate of early diffusion weighted in small brainstem stroke has been shown in this study, and the costs are huge. $10 billion and above estimated annual US cost of dizziness related emergency department care. The key challenges are transient nature of symptoms, recall bias once the episode has resolved, and the clinical examination occurring outside the episode itself. Two patterns of transient vestibular symptoms, that is TVS, acute transient vestibular syndrome. A single episode lasting less than 24 hours may represent the first presentation of a recurrent disorder like vestibular migraine or a one-off event like vertebrobasilar DIA, alcoholic intoxication, or even phenytoin intoxication. The episodic vestibular syndrome, where the recurrent episodes, each lasting less than 24 hours, includes BPPV, vestibular migraine, Meniere's disease, vestibular paroxysmia, and cardiac arrhythmias. Why this distinction matters? At first presentation, the differential is very broad. Vestibular migraine requires 5 or more attacks to confirm the diagnosis as per the classification criteria of International Classification of Vestibular Disorders, that is the Berenice Society. So a single early episode of vestibular migraine can only ever be a provisional diagnosis. Recurrent TVS patients may over proportionately consume the emergency department resources in terms of repeat imaging hyperacute stroke pathways despite a benign underlying cause. Always ask for previous similar episodes, especially in patients who have a previous history of migraine. Structured history taking, timing, and triggers, that is the titrate approach, distinguishes the spontaneous from triggered symptoms, that is STVS from TTVS, together with the central oblique peripheral oblique non-vestibular framework narrows the differential before any bedside test is chosen. So, spontaneous episodes of transient vestibular symptoms lasting seconds could be because of cardiac arrhythmia, vestibular paroxysmia, epileptic vertigo. Those lasting spontaneous, lasting minutes could be because of panic attacks, hypoglycemia, cardiac arrhythmias, vertebrobasilar TIA or vestibular migraine. Spontaneous TVS could be because of alcohol intoxication or drug intoxication, manias, or episodic ataxia if it lasts for minutes to hours. The triggered episodes, the positional situational, lasting seconds is because of BPPV or central positional vertigo. Lasting minutes is because of vestibular migraine, and minutes to hours could be because of orthostatic hypotension, postural orthostatic tachycardia syndrome, carotid sinus hypersensitivity. So the pivotal question is, are the symptoms still ongoing or have they receded or resolved? This single question determines which bedside algorithm is valid. Applying the wrong one, especially the hints in a patient without nystagmus, lowers the specificity for detecting the central causes and drives the unnecessary stroke unit reference. Ongoing symptoms with nystagmus, apply hints which is validated. Resolved or positional symptoms, use standing, not the hints plus. So hints only for ongoing symptoms with nystagmus. What does it test? Head impulse test for HI, nystagmus patterns, the test of skew, and the plus stands for the new onset unilateral hearing loss. It is validated only when symptoms are acute onset, still ongoing at the bedside, spontaneous or gaze evoked nystagmus is present. The sensitivity exceeds 95% when applied by at least moderately trained examiners. The common pitfall is that applying hints to a dizzy patient without nystagmus risks a false central pattern because of bilaterally normal head impulse test, no skew, no gaze evoked nystagmus, no hearing loss, leading to unnecessary imaging and stroke unit referrals. In one acute transient vestibular symptom cohort, hints plus could not even be applied in 73% of the patients because symptoms had already ceased. Standing protocol, the versatile option for resolved or positional transient vestibular symptoms. It is a four sequential step protocol. Spontaneous nystagmus present or absent and its pattern. Number two, type of nystagmus on positional testing, that is the Dix-Hallpike and supine roll test. Number three, direction changing nystagmus or associated central findings. And number four is assessing gait, ability to stand or walk unassisted. Use it when symptoms have already resolved by the time of examination. Symptoms are positional or triggered. There is no nystagmus, either spontaneous or gaze evoked. Hints plus would be uninterpretable in such cases. Complementary risk factors like Sudbury vertigo risk score and triage plus score can be layered into standing to further stratify the stroke risk in patients with resolved or positional transient vertigo. Unlike the hints plus, both these parameters, that is the Sudbury vertigo risk score and triage plus score, both were derived in cohorts that included the transient presentation. So Sudbury vertigo risk score, the predictor stroke risk factors like male, age of more than 65 years, and diabetes carry 1 points each. Hypertension carries 3 points. Neurological deficits like motor and sensory carry 5 points. Cerebellar, including the diplopia, dysarthria, dysphagia, dysmetria, and ataxia, include 6 points. A diagnosis of BPPV is a good prognosis and carry -5 points. Prospective cohort in 3 Canadian emergency department study involving 2078 vertigo patients. 5.3% had a serious diagnosis like stroke, TIA, vertebral artery dissection, or brain tumor. Key predictors are the associated age more than 65, presence of hypertension and motor deficits. The negatively associated, that is, good prognostication, was episodic dizziness or positional triggers. Performance cutoff was 4 or more, sensitivity 100%, specificity 72.1%. So probability of serious diagnosis by score is less than 5 score 0%, 5 to 8% 2.1%. If it is more than 8, 48 1%. Triage plus score components, there are maximum scores of 17. No triggers score is 2. Atrial fibrillation 2. Male gender 1. BP 140 by 90 millimeters of mercury 2. Brainstem or cerebellar dysfunction 1. Focal weakness or speech impairment 4. Dizziness but not vertigo 3. No previous vestibular disease 2. So the triage score interpretation is score 0 to 4, low risk of 5.9%, score 5 to 7, intermediate risk of 9.1%, score 8 to 9, high risk of 24.7%, scores 10 to 17, very high risk 57.3%, cutoff scores 5 or more, sensitivity has 96.6%, and the negative likelihood ratio instead of specificity is 0.5 here for the cutoff 5 or more. Cutoff 10 or more, sensitivity is 77.5% and specificity 72.1%. A practical guide is to carry these risk score slides in your smartphone and you can prognosticate immediately instead of remembering them for all times. So the master algorithm for transient vestibular symptoms is patient with transient vestibular symptoms. Are the symptoms ongoing at the time of examination? And if it is yes, and if nystagmus is present, spontaneous or gaze evoked, then nystagmus if present, the hints plus should be applied, and MRI diffusion weighted if central pattern of the hints plus is observed. If there is no nystagmus, then consider non-vestibular or cardiac metabolic causes, and the workup should be directed towards the non-neurological causes like ECG, Holter monitoring, orthostatic blood pressure measurement in the lying and standing position, blood workup, especially the glucose, electrolytes, particularly the sodium and magnesium, and complete blood count. If the symptoms have receded or resolved at the time of examination, positional testing is mandatory in all patients with Dix-Hallpike and supine roll testing. Apply standing protocol with or without Sudbury or triage plus scores, not the hints plus. Immediate and sustained response to laboratory maneuver supports BPPV over vestibular migraine or central positional nystagmus. If none of these are applicable, then proceed towards the non-neurological causes workup with the ECG, Holter monitoring, orthostatic blood pressure measurement, blood workup including the glucose, electrolytes, and complete blood counts. So BPPV versus central positional vertigo versus vestibular migraine. Every transient vestibular symptom patient, even those denying triggers, should receive Dix-Hallpike and supine roll testing. But a positional nystagmus alone is not equivalent to BPPV. Response pattern is diagnostic. So we have classified these three disorders based on 4 parameters. The nystagmus intensity in BPPV is strong, torsional or horizontal. In central positional vertigo, it is variable, maybe pure vertical or pure torsional. In vestibular migraine, it is low amplitude, low SPV, and low frequency nystagmus. Latency and fatigue of the nystagmus in BPPV is brief latency, fatigues on repetition. In central positional nystagmus, there is often no latency and there is immediate nystagmus which is non-fatiguing, And likewise, in the vestibular migraine, it is persistent, not fatigue. Response to liberatory maneuver is immediate and sustained in BPPV. In central positional vertigo and vestibular migraine, there is no sustained response to the liberatory maneuver. The other clues are in BPPV, the nystagmus matches the plane of the stimulated canal. In central positional vertigo, the nystagmus is often apogeotropic horizontal on supine roll testing. However, that is only when if it does not respond to the Zuma or other type of maneuver for the posterior cupulolithiasis. Direction may not match the canal in the central positional vertigo, and there may be a prominent positional vomiting. In vestibular migraine, the history of migraine headache, photo, and sonophobia may mimic the lateral canal BPPV pattern. So, these are some of the very key points that differentiate the positional nystagmus of BPPV versus central positional vertigo versus vestibular migraine. Vertebrobasilar TIA, it is the most important diagnosis to exclude, not to miss. Diagnostic criteria for probable transient vascular vertigo, brief symptoms duration usually minutes, sometimes up to few hours. Focal neurological signs may be subtle or non-localizing like dysarthria. Absence of diffusion weighted MRI positive lesion, increased vascular risk factors, ABCD2 score 4 or more, untreated atrial fibrillation, significant more than 50% narrowing of the vertebrobasilar artery. Scale of problem, around 15% of posterior circulation TIA is present with isolated dizziness, around 10,000 US patients per year. Transient vestibular symptoms precede the posterior circulation stroke in 12 to 25% of cases within prior 90 days. Secondary prevention reduced the recurrent events by more than 93% in confirmed vertebrobasilar TIA patients. The number needed to treat is 1. So, the clinical pearl is that the misdiagnosis rate for the cerebrovascular events rises to 24 to 60% when presenting complaints are mild, non-specific, or transient. Vertigo triggered by head position change is actually associated with lower risk than spontaneous transient vestibular symptoms, but central positional vertigo still accounts for 11 to 22, 11 to 12% of positional cases. So don't over rely on the brain imaging for in acute settings. MRI diffusion weighted is negative or falsely negative in 50% of the cases, especially in the small brainstem strokes when imaged early within 24 to 48 hours. CT angiography picks only 14.3% patients' sensitivity to detect acute vertebrobasilar ischemia. The non-contrast CT likewise has 21.4% sensitivity to detect acute vertebrobasilar ischemia. Practical guideline preferred MRI with diffusion weighted imaging, but negative MRI does not exclude small vertebrobasilar stroke or TIA. CT scan or CT angiography is reasonable when hyperacute treatment decisions like thrombolysis or mechanical thrombectomy are on the table, or to detect basilar stenosis, dissection, or occlusion, not as a rule out tool. MRI perfusion weighted imaging showing cerebellar hypoperfusion without a diffusion weighted imaging lesion may be useful if not widely available biomarker of central ischemic transient vestibular symptoms. The bottom line is that there is no substitute of clinical bedside testing and structured history remains central. Imaging supplements cannot replace and the clinical examination. Vestibular migraine can look just like vertebrobasilar TIA. Vertebrobasilar TIA patients are usually old, have vascular risk factors. Focal neurological signs may be present, which are often subtle during the attack. No personal history of migraine is present in such patients. Negative MRI diffusion weighted imaging does not exclude it. Significant vertebrobasilar artery stenosis may be seen on angiography, and this is a strong pointer to patients who have vertebrobasilar TIA. Vestibular migraine patients are younger, especially female. Personal history of migraine headaches of other types is present. Accompanying migrainous features like photophobia, phonophobia, and headache present. Lack of vascular risk factors are present. Positional nystagmus is low amplitude, low SPV, persistent, non-fatiguing, unlike the BPPV. Diagnosis requires 5 or more episodes of vestibular migraine to confirm as per the Barani Society criteria. A first episode of vestibular migraine can only ever be provisional because biomarkers are lacking and the presentations can be hyperacute and disabling. Patients with vestibular migraine occasionally receive thrombolysis before the diagnosis is clarified. This is considered safe with symptomatic hemorrhage occurring only in 0.5% of stroke mimic cases, but can land you in the court. So, this is a practical problem. The even the best of the shrewdest of all emergency department physician can sometimes make a mistake of thrombolizing a patient with vestibular migraine who is not fulfilling the 5 episode criteria as per the ICD-VD criteria laid down. Peripheral vestibular and non-vestibular causes of transient vestibular symptoms. The important peripheral vestibular causes are BPPV, most common, 0.6% per year incidence. Meniere's disease causes transient audiovestibular symptoms lasting 20 minutes to 12 hours, sometimes 24 hours. Vestibular paroxysmia results in brief, spontaneous, seconds long episodes, which could be many up to 10 to 30 per day. Cardiovascular causes are cardiac arrhythmias, orthostatic hypotension, vasovagal syncope, postural orthostatic tachycardia syndrome, carotid sinus sensitivity. Metabolic causes could be hypoglycemia, electrolytic disturbances like sodium and magnesium levels, which could be low, leading to hyponatremia and hypomagnesemia. Alcoholic and drug intoxication is an important cause. The anti-seizure medication, particularly the diphenyl sodium. There's a lot of patients who go to the neurosurgical services with mild head trauma, and they are being given the loading dose of diphenyl sodium. A few days later, they come up in my OPD with acute dizziness and inability to walk, that is imbalance as well. And if I get their diphenyl serum levels, they are usually very high. The withdrawal and looking for the effect and improvement, test the diagnosis before the blood reports of the drug comes. Other drugs like carbamazepine and neuroleptics, and particularly in recent days, the gabapentin and pregabalin is also responsible for dizziness and imbalance in the emergency department. Carbon monoxide poisoning is another cause amongst the metabolic or toxic levels. The other central causes are epileptic vertigo, usually lasting less than 30 seconds. It is rarely isolated. Other seizure types are especially concurrently present, or there is a previous history of other seizure types. Episodic ataxias, especially the early spinocerebellar ataxia 27B in elderly patients, which is very much responsive to 3,4 aminopyridine, is a differential diagnosis, and the genetic analysis of this is available in the National Institute of Mental Health and Neurological Sciences. And there are certain signs also on the MRI testing, the soft signs. A response to the 3,4 aminopyridine is very robust. Vertebral artery compression syndrome, that is the Bow-Hunter syndrome, is an important cause of the other central causes. Here, the test for ischemic nystagmus by extending the cervical spine and yawing it maximal to evoke the ischemic nystagmus, and if this ischemic nystagmus is evoked and if the head is brought back to the mean position, that is the straight ahead normal position, the nystagmus disappears. It's diagnostic. We require CT angiography, the dynamic CT angiography or dynamic DSA to rule out or rule in the possibility of the rotational vertebral artery compression syndrome. In large US emergency department sample, the general medical diagnosis 49.2% were actually more common than the otovestibular diagnosis, which were 32.9%. among acutely dizzy patients. So don't anchor on the vestibular system alone. This will sometimes lead you in problems by missing a diagnosis which is in fact cardiac or otherwise other than the vestibular. So recommended workup at glance adapted from table 1. There are three things: parameter, transient already resolved syndrome, acute ongoing syndrome. The bedside examination for the transient already resolved syndrome is focal plus subtle oculomotor system examination. The triggered nystagmus like head shake, vibration, and hyperventilation induced nystagmus are important in making the patient of the vestibular paroxysmia, positional testing like Dix-Hallpike and supine rule test in BPPV. Acute ongoing, the bedside examination should include focal neurological examination with subtle oculomotor examination, stance and gait examination. The algorithm for transient already resolved syndrome is standing with or without Sudbury or Triage plus scores, not the Hinds plus. The algorithm for acute ongoing is Hinds plus only if spontaneous or gaze evoked nystagmus is present. Standing to be used with or without Sudbury or Triage plus scores if it has resolved. The imaging in transient already resolved is MRI diffusion weighted if central origin is suspected. Imaging for acute ongoing is MRI diffusion weighted if central is suspected, may be repeated after 48 hours. CT or CT angiography if urgent treatment decisions like thrombolysis or thrombectomy has to be taken. Other tests in transient already resolved is ECG, Holter monitoring, orthostatic BP measurement, hearing test, and blood workup. In the acute ongoing, the hearing test, MRI diffusion weighted, no provocation maneuver to be done in acute ongoing episodes while the symptoms are still persisting. So, managing acute transient vestibular symptom, the key takeaways are structured history taking. Timing plus triggers drives the test selection before any bedside examination begins. Hints plus is only validated for ongoing symptoms with visible nystagmus. Never apply once the symptoms have resolved or even if they are ongoing, there is no nystagmus. Standing with or without Sudbury vertigo scores or Triage plus scores is the versatile evidence based choice for resolved or positional transient vestibular symptoms. You can carry these scores, that is the Sudbury and Triage plus scores, in a smartphone for a ready reference. Positional testing, Dix-Hallpike and supine roll test belongs in every transient vestibular symptoms workup even without a reported trigger. Vertebrobasilar transient ischemic attack and vestibular migraines are the key mimics to distinguish. Imaging alone will not settle it, and sometimes a very over enthusiastic, intelligent person working in the emergency department can risk in thrombolizing a patient with vestibular migraine who has not attained the 5 attacks required to make a diagnosis of definite vestibular migraine. If negative diffusion weighted MRI does not exclude stroke, false negative reach 50% for small brainstem infarcts as per this study. So what they do in Italy, in the Italian Journal of Emergency Medicine, it is published that they look for nystagmus by Frenzel goggles in patients with acute vertigo or unsteadiness. If the nystagmus is detected and is vertical or pluridirectional, it is for all particle purposes central vertigo. If unidirectional nystagmus is there, head impulse test is done, and if it is negative, it is a central vertigo. If it is positive, it is likely to be acute unilateral peripheral vestibulopathy. But if such a patient with acute unilateral peripheral vestibulopathy is unable to walk unsupported, it is likely to be a stroke in posterior circulation involving the root entry zone or the vestibular nucleus and possibly with some ischemia of the postural networks around it. If there is no nystagmus seen on Frenzel examination, but the patient is unable to walk unsupported, then it is a central vertigo. Here there is a rider, the emergency department physician, who is still a very smart fellow, should be able to distinguish between a dissociative illness from a true difficulty in walking without support. That is, a dissociative illness causing a so called astasia abasia should be ruled out. If positional nystagmus is evoked during the Dix-Hallpike or supine roll test, the BPPV is diagnosed provided it responds to the liberatory maneuver and the response is sustained. But if such a patient of BPPV is unable to walk unsupported, it could be central positional vertigo because of an infarct in the velocity storage regions of the cerebellum, that is the nodulus and the uvula. So I finish my talk here. I think that this algorithm of standing with and without the Sudbury vertigo scores and triage scores would enable a patient who says that, doctor, I was dizzy this morning but I am fine now, able to differentiate what are the serious causes and what are the vestibular causes and what are the other non-vestibular causes and how to proceed. Thank you very much. I finish my presentation here.